Welcome, Thomas. Today, we're going to delve into a profoundly important area: perinatal palliative care. This field is crucial because it offers a framework for supporting families who receive a life-limiting fetal diagnosis, helping them navigate the emotional landscape and make informed decisions during an incredibly challenging time.
Thank you, Lila. I'm really keen to understand this better. It seems like such a sensitive and complex area, and I want to ensure I grasp the nuances of providing compassionate support.
Exactly. We'll explore how effective communication plays a vital role and touch upon the ethical considerations involved. Our goal is to understand how to embrace this journey with compassion and comprehensive support for these families. Thomas, to begin our discussion on navigating the emotional landscape of perinatal palliative care, we must first understand the profound impact on parental identity. Research highlights how care provider behaviors significantly shape a parent's identity as a good parent to their seriously ill child.
So, the concept of a good parent is central here. Does this mean their decisions are heavily influenced by their own internal beliefs about what a good parent should do in such a difficult situation?
Precisely. These good parent beliefs are crucial in understanding parental perspectives and actions during these challenging times. Parents often face complex roles in end-of-life decision-making, particularly in pediatric intensive care settings where these beliefs are tested.
I see. So the emotional burden is tied to their identity and the difficult choices they face. How does perinatal palliative care specifically address this emotional burden and these complex decisions?
Perinatal palliative care, or PPHC, is a growing field that directly supports families facing life-limiting fetal diagnoses. Specialists help families navigate anticipatory grief and complex care decisions, often before the baby's birth, providing a structured framework for support.
Is that support primarily counseling, or are there more tangible aspects to help them navigate this grief?
It is comprehensive. PPHC teams facilitate memory-making activities and create palliative birth plans. These activities are designed to support families emotionally and practically, offering a sense of agency in an otherwise uncontrollable situation.
So, memory making and birth plans offer a sense of control and a way to process grief. Does this extend to post-birth care as well, or is it primarily prenatal?
Yes, it extends beyond birth. Some hospices admit babies at birth to assist with end-of-life symptom management and continue memory-making activities, such as hand or foot castings and newborn photography. This further empowers families by providing agency.
That makes sense. The unpredictability of neonatal prognostication must add another layer of emotional complexity. Are discussions about transitions from hospital to home hospice common?
They are crucial. Due to the unpredictable nature of neonatal prognostication, discussions about potential transitions from hospital to home hospice are essential. This ensures continuity of care and addresses the unique needs of pediatric patients and their families.
What about the professionals involved in providing this care? How are they equipped to handle such emotionally sensitive situations?
Ongoing education and training for hospice staff are vital, including pediatric certification and collaboration with regional children's hospitals. Resources like the End-of-Life Nursing Education Consortium pediatric courses provide valuable support and guidance.
So it's a multifaceted approach, ensuring care providers are well equipped. Does this interdisciplinary support extend beyond medical care?
Absolutely. Interdisciplinary support extends beyond medical care, involving child life specialists, psychologists, and bereavement counselors. This holistic approach addresses the emotional well-being of both the child and family.
That's a good point. Considering the child's perspective, too, even if the primary focus is on the parent's emotional landscape. How do developmental considerations factor into this care?
Understanding developmental stages is crucial in addressing children's perceptions of illness and death. Tailored communication strategies are necessary to meet the unique needs of infants, children, and adolescents, which directly impacts the family's emotional processing.
So, communication is adapted based on the child's age and understanding. And legacy building, is that part of the emotional support for the family?
Yes, legacy building and memory-making activities are emphasized to support the emotional well-being of both the child and family. These practices help families create lasting memories and process their grief in a meaningful way.
It seems like the entire process, from diagnosis through bereavement, is designed to provide comprehensive emotional support, empowering families through difficult decisions and grief.
That is the core objective. By addressing parental identity, facilitating communication, and providing practical and emotional support through PPHC, we aim to help families navigate this incredibly challenging emotional landscape with compassion and dignity. Welcome back, Thomas. Today, we will focus on the critical role of communication within perinatal palliative care. This is a foundational element for effective support.
Thank you, Lila. I'm ready. Where should we begin our exploration of communication in this context?
We begin by recognizing that communication strategies in PPHC are always tailored. They must adapt to the developmental stage of the child and the unique needs of the family. This ensures relevance and sensitivity.
So, tailored implies a highly individualized approach. Does this mean the communication style changes significantly depending on whether it's a prenatal diagnosis or post-birth care?
Precisely. For instance, communication with parents regarding an unborn child differs from discussions about an infant. The language, focus, and emotional support provided are adjusted to the specific stage and the family's current emotional state.
I understand. So it's about meeting the family where they are, developmentally and emotionally. What are the core principles guiding this tailored communication?
A central principle is recognizing the child's role within the family, even if the child is unborn or an infant. Furthermore, it involves respecting the family's inherent knowledge and expertise about their child, which is invaluable.
That makes sense. The family knows their child best. How does the hospice physician, or HP, specifically integrate these principles into their communication?
The hospice physician's role extends beyond purely medical information. They must understand the family's dynamics and actively support their emotional needs. This holistic approach is crucial for building trust and facilitating open dialogue.
So it's not just about delivering facts, but also about emotional intelligence and understanding the family's internal structure. How does this understanding translate into practical communication strategies?
It informs how information is presented, how decisions are discussed, and how support is offered. For example, knowing family dynamics helps the HP identify key decision makers or potential sources of conflict, allowing for more effective mediation and support.
That's a clear application. What about the content of the communication itself? How important is honesty, especially when facing a poor prognosis?
Honest and complete information from physicians is paramount. It supports parental hope, even when the prognosis is poor. False hope is detrimental. Realistic hope, grounded in truth, empowers parents to make informed decisions and prepare.
So transparency, even with difficult news, is essential for maintaining trust and enabling parents to cope. This seems to tie into the concept of a good parent we discussed previously.
Indeed, effective communication directly supports parents in their definition of being a good parent. By providing comprehensive information and respecting their decisions, HPs validate their advocacy and unselfish choices for their child.
So the way information is communicated can either empower or undermine a parent's sense of competence and identity during an incredibly vulnerable time.
Precisely. When parents feel heard, respected, and fully informed, they are better equipped to navigate complex care decisions. This includes decisions around advanced care planning.
How does communication facilitate advanced care planning in PPHC specifically?
Communication is central to creating a palliative birth plan. This plan acts as an advance directive, outlining preferences for pregnancy, delivery, and infant care. Open dialogue ensures the plan reflects the family's wishes and values.
So communication is the vehicle for translating family values into actionable care plans. It also seems crucial for managing anticipatory grief.
Absolutely. PPHC teams use communication to provide anticipatory grief counseling and to facilitate meaningful memory-making discussions during pregnancy. These conversations help families process their emotions and prepare for the future.
To summarize, effective communication in perinatal palliative care is tailored to the child's developmental stage and family needs. It involves the hospice physician understanding family dynamics, providing honest information, and respecting parental decisions, all of which empower parents and facilitate crucial planning.
That is an excellent summary, Thomas. Communication is not merely an exchange of information. It is a therapeutic tool that underpins all aspects of compassionate and effective perinatal palliative care. Welcome back, Thomas. Today, we're going to focus on the ethical considerations and decision-making processes within perinatal palliative care. This area presents unique challenges due to the vulnerability of the patient and the profound impact on families.
Thank you, Lila. I'm ready to delve into this. Where do we begin when considering the ethical framework for decision-making in this context?
We start with the fundamental principle that minors lack the capacity for autonomous decision-making. Therefore, decisions in pediatric care, including perinatal, involve a collaborative effort between parents and physicians to determine the child's best interest.
So the best interest standard is central. Could you elaborate on what that entails and how it differs from other standards, perhaps for adults?
Certainly. The best interest standard promotes the maximum good for the child, considering their well-being, health, and future. This contrasts with the substituted judgment standard, which applies to previously autonomous individuals who can no longer make decisions, where the goal is to honor their known past preferences.
I understand. So for children, it's about what's objectively best for them, rather than what they might have wanted if they could express it.
Precisely. Parents are typically viewed as the primary decision makers as they incorporate family values and cultural beliefs into these choices. However, physicians also have a crucial duty to protect minors from harm, which can sometimes create tension.
That tension sounds like a significant ethical challenge. When might parental authority be questioned or even overridden in these situations?
Parental authority may be questioned or suspended in cases of suspected discrimination, abuse, or neglect. The physician's duty to protect the child takes precedence when there is clear evidence of harm or a significant risk of harm.
Are there specific scenarios, like treatment refusal based on religious beliefs, where this balance is particularly delicate?
Yes, treatment refusal based on religious beliefs is a complex area. It is sometimes allowed, especially if the refusal does not pose an immediate life-threatening risk or severe suffering. However, other family preferences that are not religiously motivated may be overridden if they are not in the child's best interest.
So there's a distinction between religiously motivated refusal and other preferences, with a higher bar for overriding religious beliefs, provided the child isn't directly harmed.
That's a fair assessment. Furthermore, as children develop, their involvement in discussions and decision-making becomes increasingly important. This is facilitated through informed assent, where their understanding and agreement are sought to the extent their developmental stage allows.
Given we're discussing perinatal care, how does informed assent apply when the patient is an unborn child or an infant who cannot verbally assent?
While direct assent isn't possible, the principle still guides our approach. It emphasizes respecting the child's future personhood and ensuring that surrogate decisions made by parents are truly in the child's best interest. For older pediatric patients in hospice, it means involving them appropriately in their care discussions.
So, to summarize the first part, ethical decision-making in pediatric palliative care, including perinatal, relies on the best interest standard for minors, with parents as primary decision-makers, but with physician oversight to prevent harm, and a nuanced approach to issues like religious refusal and child involvement.
Excellent summary, Thomas. Now, let's transition to communication and prognostic disclosure, which are also deeply intertwined with ethical considerations in this field.
How does prognostic disclosure become an ethical consideration, especially when balancing hope with realistic outcomes for families facing a life-limiting diagnosis?
It's crucial. Prognostic disclosure must be handled sensitively, providing honest and complete information while still supporting realistic hope. Ethically, we must avoid false hope, which can hinder a family's ability to make informed decisions and prepare for the future.
And how does this sensitive communication impact parents' identity as good parents, which we've discussed before?
Effective and honest communication directly supports parents in their definition of being a good parent. When care providers honor parents' intentions and support them through difficult decisions, it validates their advocacy and their unselfish choices for their child, even in the face of a poor prognosis.
So, the way information is delivered can either empower or undermine a parent's sense of competence during an incredibly vulnerable time. How do perinatal palliative care teams specifically address these ethical and communication challenges?
Perinatal palliative care teams are designed to support families through anticipatory grief and complex care decisions, often before birth. They facilitate memory-making activities and create palliative birth plans, which serve as advance directives, ensuring the family's wishes and values are respected and acted upon.
So, in essence, ethical considerations in perinatal palliative care involve applying the best interest standard, navigating parental authority with physician oversight, ensuring sensitive and honest prognostic disclosure, and empowering parents through comprehensive communication and support from specialized teams.
Precisely. It's a holistic approach that prioritizes the child's best interest while profoundly respecting and supporting the family's journey through an incredibly challenging time. Understanding these ethical foundations is paramount for providing compassionate and effective care. Welcome back, Thomas. Our previous discussion touched upon prognostic disclosure as an ethical imperative. Today, we will delve into the inherent challenges of accurate prognostication, particularly in pediatric care.
I'm ready, Layla. What makes prognostication in children uniquely challenging?
One primary factor is the scarcity of population-level data for many childhood conditions. These conditions are often rare or present with complex, individualized trajectories, making broad statistical predictions difficult.
So, unlike adult conditions where there might be extensive data, pediatric cases often lack that statistical foundation. Does this mean each case is almost a unique puzzle?
Precisely. Each child's condition often requires a more individualized assessment due to this data limitation. Furthermore, prognostic uncertainty is significantly heightened when children receive novel therapies.
Novel therapies? Is that because there isn't enough historical data on how children respond to these new treatments?
Exactly. The lack of established treatment response patterns for novel therapies introduces a layer of unpredictability. It becomes difficult to forecast outcomes when the treatment itself is still being evaluated for long-term effects in a pediatric population.
That makes sense.
So, new treatments add to the uncertainty. Are there other biological factors unique to children that complicate prognostication?
Yes, children possess inherent resilience. Their young organs often demonstrate a remarkable ability to endure prolonged treatments and recover in ways that might not be seen in adults. This resilience can make predicting the course of illness and recovery exceptionally complex.
So, a child might defy expectations due to their biological capacity for recovery, making it harder to give a definitive prognosis. How do healthcare providers manage this inherent uncertainty?
They rely on a combination of clinical expertise, ongoing assessment, and specialized tools. For instance, the Lansky Play Performance Scale helps track functional decline in children with cancer, aiding in hospice eligibility assessments.
So, tools like the Lansky scale provide a more objective measure of functional status, which helps in situations where the child's resilience might otherwise obscure the prognosis. Is it still a challenge even with these tools?
Absolutely. While these tools provide valuable data points, they are part of a larger, complex picture. The fundamental challenges of rare conditions, novel therapies, and inherent resilience mean prognostication remains an ongoing, nuanced process requiring humility and continuous reevaluation.
So, to summarize, prognostic disclosure in pediatric care is challenging due to limited population-level data for rare and complex conditions, increased uncertainty with novel therapies, and the unique resilience of children. Tools exist to help, but the inherent complexity persists.
That is an accurate and comprehensive summary, Thomas. Understanding these challenges is vital for approaching prognostic conversations with families ethically and empathetically. All right, Thomas, we've covered a lot today. We started by understanding the profound impact on parental identity, then moved into the critical role of tailored communication, and finally, the complex ethical considerations, including the challenges of accurate prognostication. For your studies, I'd suggest focusing on how these areas interlink. Think about how effective communication directly supports ethical decision-making and parental identity. And always ask yourself, why is this approach crucial for these families?
That's a great summary, Layla. I definitely see the connections now, especially how communication empowers parents. I'll review the ethical considerations and the prognostication challenges, making sure I understand the why behind each strategy. It's a lot to absorb, but it's incredibly important.
Excellent. Your understanding of the why will be key. Next time, we'll shift our focus to the practical implementation strategies within perinatal palliative care, looking at how these principles are put into action by interdisciplinary teams. We'll explore specific team